Basic facts about asthma. The contrast between airways of a person who has asthma and a person who doesn't have asthma, the role of is inflammation. What happens to the airway during an asthma attack? The airways can constrict and swell up. The role of medication and understanding the difference between them. A long-term control medication prevents symptoms by often reducing the inflammation. You must take these daily, but do not expect them to give you quick relief. They are not a rescue medication. Quick relief medications such as a short-acting beta-2 agonist relax the airway muscles, provide prompt relief of symptoms. Do not expect them to provide long-term asthma control. And using a short acting beta-2 agonist greater than 2 days a week indicates the need for starting to increase the long-term control medications. Patient skills. Taking medication correctly. Inhaler technique. Demonstrate to the patient and have the patient return the demonstration to you. So if you show the patient how to use an inhaler with a spacer, that you show that you demonstrate the right way to them, they should be able to teach it back to you. Excuse me. Use of devices as prescribed, a valve holding chamber, which is why I call it a spacer, or a nebulizer. Identify and avoid environmental exposures that worsen the patient's asthma, like allergens, irritants, tobacco smoke, pollutants. Self-monitoring. Assess the level of asthma control. Monitoring symptoms and, if prescribed, a PEF measure. Recognize early signs and symptoms of worsening asthma. Use a written asthma action plan to know when and how to take daily actions to control your asthma. Adjust medications in response to signs of worsening asthma. Seek medical care as appropriate. Take medications correctly. A dry powder inhaler. Patient population are for patients who are 4 years old or greater, and they can be beta-2 agonists, corticosteroids, anticholinergic. Optimal technique is rapid. It takes 1 to 2 seconds. A deep inhalation and minimally effective inspiratory flow device, dependent. Most children younger than 4 years of age may not generate a significant inspiratory flow to activate the inhaler. The therapeutic use dose is lost if patient exhales through the device after actuating it. Therapeutic issues, Dose is lost through the device if the patient exhales through it. Delivery may be greater or lesser than an MDI depending on the device and the technique. Delivery is more flow dependent in this device, with highest internal resistance. Rapid inhalation promotes greater deposit in large central airway. Mouth washing and spitting is effective in reducing the amount of the drug swallowed and absorbed. A meter dose inhaler is for the patient population of at least 5 years of age and older. If the patient is younger than 5, a spacer or a valve holding chamber, or even a mask may be used. MDIs can be beta 2 agonists, corticosteroids, cromolyn sodium, and anticholinergics. The optimal technique, actuation during a slow, deep inhalation followed by a 10-second breath hold under laboratory conditions. Open mouth technique is where you hold the metered-dose inhaler 2 inches away from your face with your mouth open. This enhances the delivery to the lungs. This technique, however, has not been is not the best. It's better if you were to use a spacer, so you get more of the medication, so it deposits better in the lungs. Excuse me. Therapeutic issues. Slow inhalations and coordinations of actuating during inhalation may be difficult, particularly in young children and in elderly. Patients may incorrectly stop inhaling at actuation. Deposits of 50 to 80% of the actuated dose in the oral pharynx. The mouth washing and spitting is effective to reduce the amount of the drug swallowed and absorbed systemically. Lung delivery under ideal condition varies significantly between MDI due to the difference in the formulations, the propellants. For example, inhaled corticosteroid varies from 5 to 50%. Excuse me, I'm sorry. A breath actuated metered-dose inhaler the patient population is recommended for is 5 years old or greater. This is typically a beta 2 agonist. The optimal technique is a tight seal around the mouthpiece and slightly more rapid inhalation than a standard metered-dose inhaler, followed by a 10-second breath hold. Therapeutic issues may be particularly useful for patients unable to coordinate inhalation, and actuation may also be useful for elderly patients. Patients may incorrectly stop inhalation at actuation, cannot be used with currently available spacers or valve holding chambers. Nebulizer, the patient population, patients of any age who cannot use an MDI with a valve holding chamber and a face mask. Excuse me. It's typically either a beta 2 agonist, corticosteroid, cromolyn sodium, or an anticholinergic. The optimal technique is slow tidal breaths with occasional deep breaths. Tightly fitting face mask for those unable to use a mouthpiece. Using blow-by technique, hold the mask or open tube near the infant's nose or mouth is not appropriate. Therapeutic issues, less dependent on patient coordination and cooperation. Delivery method of choice for cromolyn sodium in young children may be expensive, time consuming, bulky, output dependent on the device operating the parameters, fill volume, driving gas flow, internebulizer and intranebulizer output variances are significant. Use of a face mask reduces the delivery to the lungs by 50%. Nebulizers are also as effective as an MDI plus a valve holding chamber for delivering bronchodilators in the emergency department for mild to moderate exacerbations. Data in severe exacerbations are limited. Choice of delivery system is dependent on resources, availability, and clinical judgment of the clinician caring for the patient, potentially for bacterial infection if it's not cleaned properly.